many risk factors. But there are things you can do. You can control your body mass index, BMI. You can control your neuromuscular training, or you can even experience and pre-injury level of competition by some sort of training. These are the things modifiable. But there are other unmodifiable: age, sex, family history, anatomic, structural, biomechanical, hormonal. These things you cannot modify to have a stable knee joint. Why ACL is so important? Why are we discussing about ACL? Today's Saturday. Why don't you enjoy but discuss about ACL? The moment we don't take care about ACL, these are the things that happen. The other structures like menisci do get injuries because we did not take care of the knee homeostasis. That is something matters for us to reconstruct ACL biomechanics. So there are, Dr. Ishwar was talking about the, transportal and also the transtibial technique. Those matters over the years. Dr. Howard to today's, we are all changing about the technique, and we realize that transportal is giving better anatomic ACL biomechanics and having a better outcome in due course. This is what we are thinking, and we are changing over the years. And so if you look at the transtibial vertical, a lot of grafts fail. And that was the reason why doctors thought about the transportal technique and things went better. If you have more vertical in the MRI shown, you have a much more uncontrolled quadriceps problem. So that's the reason these patients have a graft failure. At the same time, these things have been shown by other authors over the years. Of course, if we, like Professor Sisir was showing very nicely those way to put the graft. And if you put in the wrong area, this is what happens. Patient come with a 30-degree of extension leg. That is not in the even anterior to the resident's wrist. So these are some of the matters up to achieve the biomechanically better ACL. Otherwise, your outcome will be poor. We have been fighting over the years. Last 100 years, many authors have worked out the lateral extra-articular procedures for ACL reconstruction. This is something for you to be humble that we are learning. And as we learn over the years, in another 20 years down the line, what we are talking will be shown the same like I have done you today with this picture, that we were doing not the right thing. Let's see how the future will guide us. And today, when we do the ACL reconstruction anatomic with a bone patellar tendon autograft like this, such an anatomic reconstruction, the outcome, of course, have become better in those patients. These things have been taken care by Professor Lake, that it is important way to achieve that femoral tunnel, way to achieve, and depending upon the graft, is it hamstring, or is it a suspensory fixation, or is it a DPT graft or quadriceps, depending upon the graft, where do you do your tunnel, in the femur or in the tibia? Way to put is it between AM or TL bundle or in the tibia without making the middle tibial plateau finished by your drilling, way to put your graft. If you can achieve those things, your outcome will be relatively better. So this bundle concept will be much more controlled with your ACL technique. So the AM bundle was the major restraint to anterior drawer in the direct, that was discussed very vividly by all of you in the direct fiber attachment. That means where is the highest load is being borne in that area, where the direct fiber attachment is there. That is the place you want to achieve your ACL reconstruction. Of course, ligamentization will happen over the months. And then after the ligamentization, interestingly, initial ACL would have a type, original ACL will have a type 1 collagen, no type 3 collagen. I mean, the human ACL will have a type 1 collagen and type 3 collagen. But our tendon does not have a type 3 collagen. But over that ligamentization, synovialization and ligamentization, they will achieve that type 3 collagen as we progress over the time. So that really matters, that nature will take care and make our knees better. So I show this, the strength required for patellar tendon rupture will be much more forceful compared to the ACL. And then if you look at their collagen type 1 in the ligament, much percentage, tendon higher percentage. But initial ligament will have type 3, but the tendon have no or very much little type 3, but over the time it will get also type 3 collagen, even the reconstructed ACL. This is just a composition of ligaments and tendons. How do they work together with a parallel way and to give strength? We over the years were very happy to do the ACL reconstruction. We all were very happy. We came out of the surgery and told that, look, today we have done great ACL, second, third, very proud of that, until we realized the ramp lesion. Because you did a great job and your patient did not do better. And then ramp lesion were looking us, but we are not seeing the ramp lesion. As we understood about ramp lesion, we could repair it and reconstruct ACL and the best outcome as we go forward. So it is so important. Things we had never seen about the ramp and that meniscocapsular, that included posterolateral, posteromedial, and then we could achieve that biomechanical, situation to achieve the best outcome with the hard work we have done to place the right ligament, ACL, in the proper place. So if you look at this, that internal rotation without ACL is having so much further damaging the other structures, then the ITB band is actually controlling that, controlling that mechanism of higher internal rotation. So it's like a major restraint, helping not to have a more internal rotation and making that knee more stable. I'm not going to touch much about the lateral procedure. Just want to remind you that there are a patient who are a higher pivot set, biomechanically weaker in the situation. Your ACL is not going to work do better unless you realize that there are other structures are not really doing good. So that means you need to address those structures. And this is a big discussion. I don't want to go there, but I want to tell you and give you a thought process. Be careful if you have a higher pivot set patient with ACL injury. Just be careful. So does isolated ACL reconstruction restore rotational laxity after a combined lesion? No, only single ACL may not achieve rotational stability or your better biomechanics of your knee. You will have to address other structures which are along that side. So all this anatomic on the lateral or in the medial side, you need to take into consideration for your ACL stability. People from Europe, France, Lyon, London, America, Japan, everybody, and the Statement Clinic, Dr. Robert Laprade, all of them have a different thought process about those making the high pivot shape and those subtle issues in the ligament on the lateral side. However, there are some more things for us to learn according to this East Coast, one of those paper. It says that concomitant injury to anterolateral structure, it's that 93% of ACL injured patients had ITB lesions at surgery 3 weeks after injury. So something we do miss. 70% of ACL patients had an ITB lesion on MRI 4 weeks after injury. So it is something food for thought that you think you have done a great work of ACL reconstruction, but you have not been able to achieve that biomechanical stability of this patient, which is created by other structures. So you need to think about that. So is the ACL really an effective resistance to rotation torques? Are we moving towards the concept of ACL restraints anterior drawer or lateral extraarticular procedures, resistance internal rotation? Those things you can discuss in our symposium today or later on also. So there are also both double bundle and anatomic single bundle controlled pivot rotation, but at time zero. And in truly isolated ACL transection, and the changes are tiny. Evidence for PLB controlling pivot shift clinically is very weak. You know, I was told many years that posterior lateral bundle does work for the pivoting system. If you only reconstruct anteromedial, it is great for an anterior translation, but pivoting PL bundle is great. But in reality, many doctors are working on that, doing a lot of research, and not of the same opinion. So their things are changing. So that is something to think about. So pivot grade correlates with lateral compartment AP translation. So these are something we have to also, measure pivoting of our ACL to have that biomechanical consideration. So I would like to tell you, over the years, with very much humility in my own work, ACL, I would say that is critical to save internal homeostasis of knee joint, no question about it. And also, it works with other structures from capsule, menisci, ALL, meniscocapsule structure, etc., to make that rhythm. It's very interesting. You have to feel it. Unless you feel it, you will not see it, or you will not appreciate it. Sorry. So, excessive tibial internal rotation and its prevention is important with ACL. Very important. So you cannot ignore other structure while thinking about ACL. ACL biomechanical and physiological consideration cannot be discussed without mentioning other structures. So really, it perplexes me why same surgeon with the same type of ACL ligament reconstruction done to the patient, their patients, cannot produce the similar results. Thank you.
Thank you, Chakra sir, for your wonderful presentation, sir. So there are a few questions. So
yeah, please.
Yeah. So one of the question is asked by the Jagdish Thapa, and he's saying that a mycoid degenerated ACL, does it has equal mechanoreceptor and proprioceptor properties? Do you suggest for surgery if it is an incidental finding while doing MRI for other cause?
Thank you, Jagdish. I think that's a great question. Let me tell you, we are working in arthroscopy, have been, we have been made very surprised by mycoid degeneration. If you look at the patient with the mycoid degeneration, when you do the arthroscopy, the ACL is like a ciliary, structure is so bulky. It not only bulky, it actually takes the space of the lateral meniscus. It actually passes over the lateral meniscus root on the lateral side. If you look at I cannot answer your one part is a mechanoreceptor because that part I cannot answer you. But what I can answer you, that particular ACL is so thick, it's so bulky. Patient, when you bend their knees, they have so much pain. We don't have a really clear-cut answer, and we all do a debulking. We have discussed this before also. Shall we go for an ACL reconstruction, or we just debulking? In my experience, let me tell you, I have done not a single ACL reconstruction in the mycoid degeneration cases. I have done debulking. These patients, in a couple of years follow-up, they are better. They do have some pain, but they are better. That's all I can tell you. I hope that answers your queries.
Fair enough. Any other panelists or senior surgeons who have a further elaboration of the answer to Jagdish's question, sir? Anyone, sir?
I also agree. I also agree with Dr. Pandey's opinion that the mucoid ACL does not. It is not a normal ACL. Like it must definitely have the mechanoreceptors, all those replaced, and they usually have a complaint of some sort of not only pain but instability also. So that gives us the idea that the normal mechanoreceptor might be replaced by a mucoid degeneration of the patient. So the concept of decompressing, like Dr. Pandey said, does help to some extent. But for me, practically, I tell my patient that if this does not help, sometime we might need to do a ACL reconstruction. Thank you.
Vijendra, any more questions?
One question from Vivek. Chakra sir,
Yes.
Vivek is asking that how to decide the need of anterolateral ligament reconstruction or lateral extraarticular tenodesis.
Thank you, Vijendra. Let me be very honest with you. A patient with a high pivoting thing, like, like 3+ is jumping the knee. There is something, this particular idea I just put today, there is something to think about. I am not the guy who has been doing a lot of, lateral, tenodesis procedures. I have not done. But this has been advocated, and some of the patients with a high pivoting, they are not happy in the follow-up, meaning that there's something to be addressed. So that is my, simple suggestion today is just be careful. If you have a very unstable knee, just to give a thought about that lateral tenodesis procedure. But this is a big discussion in the arthroscopy arena today. We are all discussing lateral extra-articular thing. So some of you can comment and help, Vivek about that. That's my thought process.
Okay, thank you, sir.
Okay, Dr. Vijendra,
Yes, sir.
regarding the mucoid regeneration,
Yes, sir.
there are two issues can be there. One is Dr. Pandey said there can be instability because the mechanical receptors are not acting upon. They are being degenerated with the disease process, so they have not been functional. Another could be patient come with the history of pain also, impingement, especially in the flexion of the knee, and sometimes in the hyperextended, attempted hyperextension of the knee also. I think this pain is the major indication for the a surgery to be done, and the patient asks for any treatment. And in one or two cases, I found like after decompression, following this impingement with a complaint by the patient as a pain, then in a few months of period, patient came with features of instability. And he gave the history of some sudden twisting movement while standing from sitting position and so. And this further weakens as well as that this all this feedback mechanism is altered, that can lead to some instability in the later stage also.
Thank you, Arjun, sir. I think Amit sir want to tell anything. Amit sir?
Yeah, thank you. I absolutely agree with what Chakra sir and Arjun sir is saying. But what we have to understand is that MD ACL is usually it is reserved for someone who is little in the older age group. Usually, if we see our 67 cases, analysis of 67 cases, the mean age was 52 years. So as long as literature and our practice is concerned, we do not do ACL reconstruction, provided we can preserve some amount of the ligament. And the issue is how much is to decompress. That is the important point. If you can preserve certain amount of the ligament, there is obviously no point of ligament reconstruction. So the ligamentous reconstruction after surgical approach to the mucoid degeneration comes when you have to remove whole of the ligament. So this may happen in very minimal and the nominal group of patient, in which in an attempt to decompress your ACL, you have to remove 100% of your ligament fibers. So even if you remove 100% of the ligament, there are a lot of study, a study of 46 cases by Vivek Pandey. Then there are some Indian studies on mucoid degeneration, and they have said that even after complete removal of ACL, very few patients they present with instability. And these are again a very limited group of younger people in which MD ACL is very, very rare. So probably as of now, the standard treatment protocol, I agree with Chakra sir, of conservative for me. Even I remove 100% of the ACL. conservative, and the patient is symptomatic later on, probably a second stage ACL reconstruction can be advised for the patient. Thank you.
Thank you, Amit, sir.
Yes, Amit. I mean to say is in my patient, that patient is around 40 years of age. And in any ladies, many ladies patient also, we do get encounter this mucodegeneration. And mucodegeneration do occur in almost every patient, those who are more than 50 years or so. So that in that situation, we do not do anything. But in a relatively younger patient, we need to intervene.
Thank you, Arjun, sir. Thank you, Chakra, sir, for your wonderful presentation. Due to time constraint, we have to move forward. So I could like to request our next speaker, Professor Arjun Lamisani, sir, to talk on surgical management of ACL injury.
Okay, is it share?
Yes, sir. Just you have to full screen, sir.
Okay.
So first slide, I understand.
Yeah, I'll see.
Sir.
Okay, thank you, Virendra and Nagmari, for giving this opportunity, and Scientific Committee of Arthroscopy Society of Nepal. I'll be talking on very vague topic, the surgical management of anterior cruciate ligament injury. And this non-operative management of anterior cruciate ligament injury is poorly tolerated by particular group of patients, like very young active adults and in the skeletally immature patients, because they have to go long way. And so that in that due course of time, is Dr. Pandey said, there are a lot of biomechanical changes they do occur, and that can lead to destruction of the damage of the joint as a whole. And that can lead to recurrent instability and development of other condyle and meniscal lesions and other ligamentous injury as well. The success of any anterior cruciate ligament surgery depends upon proper understanding of anatomy and biomechanics, what we discussed in detail just now. The patient selection is very, very important, because the patient, those who are overly apprehensive and not compliant, the post-operative event may not be very good. The quality of graft is very, very important, and tunnel placement is said to be one of the main cause of failure in anterior cruciate ligament reconstruction. Although there are a lot of debate around about what is the ideal side of placement of tunnel in tibia and femur, including different technique we just discussed. The fixation of graft is another issue, and rehabilitation plays an important role. The anatomy, we have already discussed in detail about the bundle concept, direct versus indirect ACL femoral attachment, and the ribbon concept as well. I'm not going any more detail on this. The only thing is, like, while making a femoral tunnel, we should try to customize on the fixation of the graft at the central direct ACL fiber attachment on the femoral side. Biomechanics, it has already been discussed. Needs very complex knee joint with shifting contact points, pressure, and axis that are affected when a ligament is injured. The ACL is one of the interarticular ligaments, has a strong influence on the resulting kinematics. So it has got main important role of anterior and medial translation, so that this rotator axis moves medially. That can lead to stress on the lateral and posterolateral structures. So this is one of the clinical scenario where if there is a associated undiagnosed posterolateral structural insufficiency and we reconstructed ACL only, the ACL will definitely fail in days to come. The diagnosis, we need to check the relevant history and examination. And the main MRI imaging can provide confirmation of ACL injury, and that also assists in identifying the concomitant knee pathologies like other ligaments, meniscus, and articular injuries. And the arthroscopy is not used either solely for the diagnostic purpose, but in due course of arthroscopic surgery, it can modify the type of surgery after seeing intraarticularly. And the surgical treatment options can be a reconstruction and a repair. And reconstruction can be non-anatomic and anatomic. In anatomic also, single bundle and double bundle concept is there, what we discussed already. The indication of surgery, Dr. Pandey elaborately explained about the indications why we need to reconstruct the ACL. The timing, the principle is this should be reconstructed if indicated as early as possible. Once the following criteria are fulfilled, like swelling in the knee must be down to near normal levels. Range of movement of the injured knee must be nearly equal to the uninjured knee, and there must be a good quadriceps muscle strength before going into reconstructions. And in several studies, they have found that once ACL reconstruction has been decided, and this should be done before 5 months of the injury, because that after that, that can lead to injury of the articular cartilage and menisci. A graft option, there are various pros and cons to each of the different choices. And in our context, autograft is the mainstay of the graft, what we options, what we do have. We need to discuss with the patient about the graft being used and its rationale. That should be based on the patient's specific factors like patient age, skeletal maturity, the activity level, and supported by the evidence and the surgeon's preference, and the availability of the fixation devices as well. This bone portal tendon graft has historically been the gold standard for the anterior cruciate ligament, and it also has got some advantages and disadvantages, and it gives a consistent size and shape of the graft, and there is a strong bone tendon interfaces, and a bone-to-bone fixation is possible, and there is a very good and early bone-to-bone healing. And in several studies, it has been found that it has got a less failure rate, but it has also got some disadvantages also. There is always a risk of patellar fracture. There can be a patellar tendonitis, patellofemoral pain, especially in the patient who need to do kneeling and other up and down activities. And donor site tenderness remain for a long time, and cosmetically there can be a bigger scar. The hamstring tendon, the use of hamstring tendon has increased these days, and even though this bone patellar tendon has been taken as a gold standard, and the outcomes and results of other graft options are compared with the bone patellar tendon, and this hamstring graft has got a stronger graft, and a smaller incision lead to cosmetically beneficial, and this can be used in skeletally immature patients, and it doesn't give rise to any anti pain like bone patellar tendon bone. But in these several studies, they have found that there are some conflicting results in research have been found whether these hamstring grafts are slightly more susceptible to elongation, like stretching, which may lead to increased laxity during the objective testing, and there can be increased risk of failure or chance of increase the frequency of ACL revision, and there can be a persistent pivot shift test, and there is a less chance of return into pre-injury activity. And quadriceps graft can be a central 1/3, central third graft. Recently, the quadriceps tendon has gained popularity for the use as a graft sources, and there are numerous studies. They have been found that it has got a very good outcome compared to hamstring and patellar tendon autograft, and some say that this tendon is being underutilized so far, and it can be used with or without bone plug, and it can be used even for the double bundle reconstruction as well. And recently I tried to search in the literature also, but I could not find the superficial quadriceps graft as it was presented in our Nepal Orthopedic Association Conference. I also tried to see what is the type of graft we can achieve and what could be the usefulness of it, so that I could find very good flat graft with a length about 34 centimeter that I could quadruple it, and it was more than 8 millimeter in diameter. And postoperatively, patient has less knee pain and outcome was very good. So that I found this superficial quadriceps is one of the viable options in the surgeon's armamentarium. Perennial longus graft, this is also being used these days. The functional outcomes and results are comparable to the 4-strand hamstring tendon graft, and there is a minimal or no donor site morbidities, and we can be considered as a potential graft of choice in the ACL reconstruction. It has got a length of more than 30 centimeter. Even with that, it can be used by a double stent or a double stent, or even triplicated, and we can have a very good graft for the ACL reconstruction, and can be used for the PCL reconstruction also. And reconstruction type, as I mentioned already, there can be non-anatomic, there is a traditional one. As we discussed earlier, this is a transtibial technique, and here it gives a sagittal stability, but less rotational stability. And anatomical one, this is the current approach. Here, the femoral till is done through the portals. We can either use a single bundle or double bundle, depending on the patient characteristic and expertise we do have. And the transtibial technique with the dependent transtibial drilling techniques, accurately and reliably addressing the femoral ACL footprint is very, very difficult. So it requires notchplasty. We need to put the tibial tunnel posteriorly to prevent impingement, and it becomes extremely vertical and non-physiological graft. It provides anteroposterior stability, but rotational stability doesn't give. Here I'll be talking on single bundle anatomical technique. Here the goal of anatomical ACL reconstruction is to regain the stability and return to pre-injury activity level. Here, since we are putting at the site of footprint, the less notchplasty is needed, and the femoral drill is done from the intermedial portal, and femoral and tibial native insertion of ACL at the footprint can be recreated, and the graft will be more oblique, and it's like a natural graft placement. And if you see here also, this tunnel is at the center of the femoral footprint. There is a footprint is around the tunnel mouth. Regarding the tunnel, tibial tunnel, since tibial tunnel doesn't guide for the femoral drill, it is made independently, and these are the some of the bony and soft tissue landmark to put the tibial tunnel. Here, if you see here, this is this blue part is the tibial footprint. Though it can be some like disagree with the ribbon concept what we had discussed before during our anatomy presentations. Here, this is the entry horn of lateral meniscus, and these are the lateral and medial intercondyle tubercle and lateral intercondyle ridge, and this is the Parsons knob. It is said to be the anteriormost attachment of tibial attachment of anterior cruciate ligament. So if we see from this corner, from this intercondyle ridge, medial intercondyle ridge corner to the lateral intercondyle tubercle, almost halfway between this is the site of this insertion of guide wire and making a tunnel around there. And for that, you got to examine this is the anteriormost attachment, this is the anterior attachment. This is the almost point exit of the guide wire for making tibial tunnel, and this is after insertion and fixation of the graft. Then we come to fixation of the graft. There is no clear consensus on the superiority of the aperture, suspensory cortical or button graft fixation, or screw, that is metallic or biological versus button graft fixation. The choice of the graft fixation depends upon surgeon's preferences, choice of the graft, and surgical technique. These are the different type of fixation devices we can use in our setup. Here there are certain fixation devices used for the femoral fixation and for some for the tibial fixation. Femoral fixation most commonly are the innobutton fixation and interference fixation, or there are intrafix or the crosspin fixation are also options, but these are not very usually available in our part. Sometimes you can use a post and washer. And the tibial, in the tibial side, you can use the interference screw or intrafix or post to the washer. And the tibial fixation is less secure and reduced bone city. And so the angle of force is in line with the graft, and the bone strength falls rapidly away from the joint line. So always tibial fixation side is the weak link, then on the femoral side, because here the bone density is also high, and because of this oblique tunnel from the accessory intermedial portal and the pool of the this graft, it does not fit with doesn't parallel with the direction of the femoral tunnel. And anterior lateral ligament reconstruction, we have already discussed it, and there are very few indications like high-grade pivot shift, persistent pivot shift, even after anatomical anterior cruciate ligament reconstructions, and in case of revision setting also. And this ACL surgery is not free from complications. There are several loops to cause complications in ACL surgery. Pre-op considerations like patient selection, as I already said, non-compliant over apprehensive patients may not give a good result. The timing of operation is very, very important. And medial compartment osteoarthritis with anterior cruciate ligament insufficiency, here the patient may not be satisfied because of the osteoarthritis changes and the pain. Graft harvest, sometimes you can have a premature amputation of the graft and the graft becomes short. And sometimes because of the small stature of the patients, the graft size will be thin and shorter also. Sometimes there can be a problem of dropped graft. There are a lot of issues whether to reuse that dropped graft with the disinfecting or use another graft. There is always issue of controversy. The improper femoral tunnel, if you put an anterior femoral tunnel, that become tight in flexion and it become lax. If you put posteriorly, then there can be a chance of posterior blowout and tightening during extension. If you put a central or the vertical tunnel, it does not prevent a rotation instability. And improper tunnel, tibial tunnel, like if you put anteriorly, it can lead to graft impingement and fixed flexion deformity. And if you put a posterior tunnel, it becomes lax in flexion, and that can lead to instability. And remnant preservations, it is the current issue of like interest. All the significance of this preservation of ACL remnant is this can be a very good anatomical landmark it enhances the graft healing. It helps to early recovery and returns to pre-injury activities. And it also gives the better proprioception and better subjective function are also there. It promotes the synovial covering and revascularization, and more post-operative knee stability and clinical scores are good. And there can be a selective bundle reconstruction also is there. You have to assess the remnant, and you have to identify the bony landmark, and careful drilling is to be done to cause less damage to the soft tissue. And a terminal perforation of the tibial plateau should be done with a low speed drill or by hammering also. And after, once you have fixed it, then you have to check whether there is impingement or not. Sometimes there can be physiological impingement can be accepted. And the primary anterior cruciate ligament reconstruction, there is a historical report of open ACL repair was not favorable with a stiffness and failure leading to instability and high reoperation rates. The precise understanding of anterior cruciate ligament biology and the development of arthroscopic technique have prompted renewed interest in ACL repair. So also advance in MRI imaging helps to plan for the possible repair candidate preoperatively also. The rationale of anterior cruciate ligament repair as it restores the better native ACL anatomy, biomechanics, and neurosensory functions. The indication would be recent injury. There is some say up to even 5 months, 6 months, or can also be repaired. And a non-contact injury is a proximal ACL avulsion or tear in the proximal most part, according to the Shermans. It's a type 1 or 2, good quality tissues, low grade preoperative pivot shift. These are the indication for primary repair. These are the different techniques of primary repair. The refixation of the suture anchor. Here the internal bracing, the repair, then the internal bracing with the synthetic material, and the dynamic interligamentous stabilization. Here the after repair, this tibia is maintained and the posteriorly during the flexion so that it can be braced. No stress will be there at the repair side. And these are by using
Arjun sir,
collagen
please hurry sir. Arjun sir,
Oh, okay.
we are running out of time.
Okay, this is the new wear technique, and then these are the prognostic factors. Is I have mentioned before also, and this ACL avulsion is that there are multiple methods have been described. Displaced avulsion fracture include cancellation screw, staple, sutures. Here this is the suture technique. You can fix it with the help of arthroscopic technique also. And the conclusion, the treatment of ACL injury is a dynamic and evolving field. Strategy change as we better understand the native knee kinematics, basic science of ligament healing, improved surgical technique, and better recognition of major cause of ACL surgical failure. Thank you.
Thank you, Arjun sir. So due to the constraint of time, we have to move forward. Our next session is about the panel discussion. And there are a few questions in the chat box. So I will request Arjun sir if he can answer that question in the chat box, sir.
Okay.
So now we move to second part of the webinar, that is a panel discussion. On behalf of Arthroscopy Society of Nepal, I would like to welcome our expert panelist, Professor Arjun Lamisani sir, Dr. Ishwar Pradhan sir, Professor Amit Joshi sir, to join the session. And this session will be moderated by Dr. Nagamani Singh and myself. So we will not be going in detail, rather than we will be more discussing towards the basis of ACL management, focusing on single bundle ACL reconstruction, which is commonly done in our part of the world. Dr. Nagamani, are you there? Dr. Nagmani? Dr. Nagmani?
Yeah, I'm there. Sorry. It was a network problem.
Okay, Dr. Nagmani, you can continue and you can take over this session.
Fair enough. So I'm not seeing Amit sir. Is he there?
Yes, yes, I'm around. I'm around.
Okay, sir. Okay, sir. So good evening to everyone. And then ACL has been such an interesting topic. We can see it in our chat box yet. So we decided to have a basic topic about ACL, but then you see our senior panelists all talking, moving from basics to highly advanced topics. So I promise we'll keep this panel discussion focused on the basics of ACL. Now, anatomy, physiological basis of surgery, and everything has been discussed. So the panel discussion, we'll try to make it short since due to the time limitations, and we'll only focus on the basics of a typical ideal single bundle ACL reconstruction. So I hope this panel discussion enlightens some of our younger colleagues and they take away some messages out of it. So here we are. So the goal is just to talk about the basics of ACL injury. I'll start with a case scenario, and which is an actual case, but I'll be discussing every step of the ACL management based on that single case rather than taking multiple cases, since it's an endless topic. So we start with the first one. So this is a case of a 30-year-old male, and he's a national volleyball player. Had a twisting injury 2 years back and has symptoms of instability, basically inability to continue games and pains. On examination, anterior drawer, latchman, pivot, everything was positive. McMurray's was positive, and the rest of the tests for multi-ligaments were negative. So this is the X-ray. The question is, you can see that this radiograph is pretty normal out here. So I would like to start the discussion with Amit sir itself first. So Amit sir, do you actually do radiographs when you have such a clinical picture in all the cases where you have classical signs of ACL tear, signs and symptoms of ACL tear, or you just move directly ahead with an MRI?
No, X-ray is compulsory. X-ray is essential because there are so many things that can be seen in X-ray as well. Yes. Right from the stage of osteoarthritis, which is very, very important to decide the future course of this thing. And then there are so many telltale signs of ligamentous injury or some other injury associated with it. So probably X-ray is a must.
Sir, please enlighten some of the signs on radiograph for our younger colleagues who don't know what are to be seen. Just the names so that they can later on go and see it.
So you can see the Steiner's lesion on the lateral side, which will indicate the ALL injury. That what is called as an ALL injury, which is called as a next to pathognomonic to the ACL tear. And exactly. There are cartilage flakes you can see, because some literature say that about 18 to 30% of these ACL injuries, which is usually chronic, are associated with the cartilage lesion. So if you do a proper views, you can see the cartilage lesion. In your lateral view, this is not true lateral, but in your lateral view, I can see a deep sulcus sign. You can see there. Yes, the deep sulcus sign can be seen, which is also a feature of this thing. On top of that, even in normal X-ray, the medial joint line, lateral joint line can be, widening and all those things that will indicate, associated injuries as well.
So fair enough. So we all agree to the fact that it has to be started with a radiograph, and irrespective of patient comes to you with an MRI, you invariably get a radiograph. Irrespective of your MRI telling you that there is a ACL tear, you need to get a radiograph, as Dr. Amit Joshi sir mentioned to us. And those were some of the signs you need to see in order to rule out the other injuries. Now, so in this case, the radiograph was normal. And then the patient had an MRI done outside itself, so we didn't think it was viable to repeat an MRI. My question to Arjun sir. Arjun sir?
Okay.
So could you please read the MRI, sir? These are the only films which we have available, and the patient could not afford the second MRI. So your readings on this film, sir. If you need some more films, I'll give
Okay.
it to you, sir.
Okay. Can you give more?
Yes, sir. That's the whole sequence we have, sir, of this patient.
Here I can see the ACL. ACL is not there. Okay.
ACL is not there or the cuts are not there, sir. That's the pertinent question, because
At least in
if
this
you look at
quarter,
it,
there is no ACL.
there's no ACL. So you are not able to visualize because of the poor quality of MRI, right, sir?
Might be, because I don't see any stump also here.
Exactly, sir. So what?
And then I can see some. Okay, there is a little bit translation is also there. There is some buckling of PCL also. You can see in the first first MRI.
Okay,
And
sir.
here also, these are also in the lateral tibial plateau. There is a contusion. This is also a telltale sign, indirect sign.
Okay, sir. So when you don't have proper films, you advise us to look at the indirect signs more frequently, right, sir, rather than repeating the MRI. So this case has a meniscal tear along with ACL. We won't be going into those combinations. We'll take this as a primarily an isolated ACL tear, sir. Now the big question: what is your choice of graft in this, sir, Arjun, sir?
This is a basketball player.
Yes, sir. National basketball player.
If you see
said volleyball player.
Oh yeah, national volleyball player, sir. I take my words back.
Okay.
Okay.
Okay. If you see in the literature, they said
no, sir. Your option, sir. What would you do if you received this patient rather than in the literature? What would you do? That's what the younger colleagues would want to know rather than just the literature.
I do see to the patient. I do see to the patient and discuss about the possible options of the graft. Basically, we have two options here. One is hamstring and another is a bone patellar tendon graft. And the hamstring graft would be definitely like beneficial in terms of return to his pre-sports activities. And
so you'll give options to the patient, right, sir?
Bone patellar tendon, yes.
Parents. You'll give options to the patient, right, sir?
Option to the patient. Both pros and cons will be discussed. And ideally, this bone patellar tendon graft would be good for him because he wants to play again. And it is in literature also, it is said that it gives more stability and the chance of return to pre-injury level of activity is high.
So I would like to ask you, Arjun, sir, if you know that BPTV is going to be a better option for him, why are you giving him an option of hamstring graft?
Because Nagmani, and these days I do many patients, they do come with, previously we used to do bone patellar tendon only. They used to have a big scar on the anterior part of the knee. 2-3 patients, they have come with that new technique has come with a little bit, little scar. And so I would like to do that one. And so that cosmetic issue also comes in action.
Iswar sir, your thoughts on this, sir? Your graft choice, would it change or how would you decide what to use? Whether you would give an option to the patient or you choose it for himself based on his athletic activities and other stuffs?
You're definitely right in saying that the sportsmen, like they need to have a bone, that the literature and the current understanding is there that the engulfment or the incorporation of a bone graft is earlier than that of the soft tissue graft. But it depends upon, there are also people who also believe that the soft tissue graft is the results of using soft tissue graft in an athlete is also as same as that of using BPTB graft. I usually do not do a BPTB graft and I usually do a hamstring graft. And it depends upon the patient, what level of activity he or she is. He might be a volleyball player or
he is a volleyball player, sir. So what would you give it to him?
Definitely you should do a BPTB graft for that patient, because there are studies which show that the incorporation of the bone into the tunnel is earlier, and you can start rehabilitating the patient from the sports point of view earlier by 3 months or 3 to 6 months. But there are now people who are saying still that in the majority of the cases everywhere in the world, hamstring has become the choice of graft, and even in sports, people people are using that.
Fair enough, sir. I would like to know Amit sir's take on this, sir. He's a national volleyball player, and would you still take a hamstring graft, or you would want to do something else for him, sir, and your reasons?
You see, Arjun sir, sir, all agreed. I also agree that BPTB is a graft of choice in this group of patient, because it's not because of the failure, because of the obvious reason that if you put a soft tissue graft, it tends to become lax a bit in its rehabilitation phase. So if you have a grade 1 laxity in a volleyball player, which is essentially a jumping activities, the patient is not going to tolerate that. So probably that is the reason why BPTB is a graft. But I liked your question regarding why I would counsel for both if I know that the patient does better with the BPTB graft.
Exactly, sir.
Yes, that is a very important question, and most of our patients are not that much educated. So based upon our patient, if their education level is very good, I explain them that people do with the hamstring graft also, but these are the disadvantages, and return to sports maybe at the same level may not be possible with the hamstring graft.
Right.
Yes, and I'll give him an option of a BPTB graft.
Okay,
and another
the,
issue is
the additional reason might be that, sir, hamstrings are needed for the explosive nature when you have to take off from the landing position, or you have to move around, right, sir?
Yeah,
so
that's
you would not want to compromise it. So there is no option of giving an option, right, sir? Or
Absolutely.
you would still give an option? Yeah.
No. If this is a national volleyball player, he wants to go back to the volleyball at the competitive level, and he doesn't want a BPTB graft, this is not my patient. I'll send him out and say that you go, whoever wants to do your hamstring graft.
We'll take out some other senior surgeons' take on this, sir. Rajiv, sir, I can see you on my screen. Can you tell us, you agree with Amit, sir, or you have something different regarding the patient choice or surgeon choice, and what are your graphs on this?
See, the thing is basically there's a lot of noise here.
Kindly mute.
So basically, the first graph.
Vivek, please look at it and mute others. Yeah.
Yeah.
Okay.
So the first graft of choice for this patient, considering everything, would be a BPTB. Okay, everybody agrees to that.
Sir, everybody is talking about BPTB. Why not quadriceps, sir? Because
just one sec. One minute. I'm coming to that. Okay. So everybody's choice the first choice would be a BPTB, right? But then you have other choices also. Yeah, you have other choices. So when you counsel the patient, you have to tell the patient about different grafts and the graft that you think is the best for the patient. Okay. Because see, the patient moves from surgeon to surgeon. Okay, like everybody realizes, the patient moves from surgeon to surgeon. You must give him the best graft choice. Now, there have been lots of patients who have come after listening to the whole story about BPTB or hamstring. They do not tend to choose that graft. Okay, but you must tell the patient what is best for him. Okay. Now, the explosive jumping that you're talking about may not be very explosive in a volleyball player. That probably would be fit for somebody who is a 110 meters hurdler. For that patient, these plyometric players, right? For those people, definitely, the hamstrings is very, very important. But for a volleyball player, I think if he chose a hamstring graft, I would do it for him if he chose it. Provided I tell him that bone patellar tendon definitely has more advantages, if you look at it, compared to the hamstrings. But you have to go with the anterior knee pain. You must tell that to the patient. And I mean, it may not be so common, right? But anterior knee pain, the patellofemoral OA, the small, occasional, very rare chance of a patellar fracture, all that is also you must tell the patient. Because if it happens, you must have told him that.
Okay, fair enough,
what I
Rajiv sir. So we'll see what is there in the literature regarding this. So when you look at it, the graft selection has to be individualized. That's what's the recommendation from JAAOS. And they say that appropriate graft selection is essential to optimize outcome, and that has to be individualized based on the needs of patients. And that's why we all agree to this, that the graft choice has to be individualized. However, for ACL reconstruction surgery as such. Regarding the choice for the patients, if you look at it, it's the literature says that it is important to discuss with the patient who will be undergoing ACLR regarding the choices of graft you give. And that's the side which Rajiv sir, Arjun sir are on. And Amit sir says that he would not give it, because in our context, it's fair enough that if you give them multiple choices, they might land up choosing not the good ones. So, but the literature supports Rajiv sir and all. So you should give an option regarding the choices of graft, but it has to be a very well-informed decision from the patient rather than halfway given decision regarding the choice of graft. Regarding the quadriceps graft, like I said, it's an underrated graft, right, sir? Because it's been talked about a lot, but not a lot have been preferring it over hamstrings. But when you look at literature, they say that it's equal or has better functional outcome than your hamstring graft. So even if it is an explosive or non-explosive sport, but would you take that chance for a national volleyball player rather than choosing a quadriceps graft over hamstring when the literature says it's better for your, it has better outcome? And most probably it's still the shadow graft which I see, because despite increasing evidences on quadriceps, very few surgeons are picking it up. Now the second thing I would want Amit sir to take it. Sir, for you, does the graft size matter, and what is your optimum diameter, sir? Any particular reasons for choosing a minimum diameter in females or males or in sport athletes? Do you have your preferences for your graft diameter, Amit sir? Amit sir?
Yes. To answer to your question in a very simple way, is that does the graft size matter? Yes, it matters. What is the ideal size of the graft for me? Depends upon various factors. Number one, either I am able to preserve the remnant. What is the amount of the remnant that has been preserved? And what I was able to do with the remnant, that will decide. If I do not have a remnant preserved, the smallest size of the graft I will definitely choose is something which is 8.5. I will try to get a 8.5 if I remove all the remnants. If I can preserve good amount of the remnant, probably 7.5, 8 graft will be good for me.
And any variations with regards to the sex of the patient, sir, male or female? Do you tend to go lower in females or males? Or any differences for you, sir?
Yeah, most of the time, Nagmani, you are not able to, you are left with whatever size graft you have, until unless you harvest from some other side. Either you harvest a quartz or harvest from the other side. In case of female, we have found that the graft size are relatively smaller compared to the male, but still not very small graft size I'd love to put. Somewhere around 7.5 to 8 also good for the female.
Fair enough, sir. So your cutoff is 7.5, right, sir?
I will say 8. I will say 8.
Okay,
yes.
Sir. So 8 is Amit, sir. So Arjun, sir, your choice of graft, sir. How much is your preferred diameter, sir? Minimum, and does it vary or not?
That depends upon the age, Dr. Amit said. Depend upon the size of the patient also, sex of the patient and size of the patient. In many conditions, Nagmani, I have found like if I like to increase the size of the graft and the tunnel size, and you do injure the anterior horn of lateral meniscus as well as some part of the lateral intermuscular intercondylar ridge also broken. And so that can vary with the patient to patient. But my cutoff point, if the patient is thin, lean and thin, and the short stature with the female sex, then it should be more than at least 7.
At least 7.
And for the
okay.
for the male patient, mostly more than 8.
Okay.
8 or
Fair
so.
enough. Fair enough, sir. So we move quickly, and I've done some literature review for that. And like you can see there, the minimum diameter which people say it has to be 7. And with every 0. You see that the graft diameter between 7 and 10 mm resulted in 0.86 times lower likelihood of re-tears with every 0.5 millimeter increase in the graft diameter. So graft diameter does play a role. And preferably, if you get a graft size lesser than 7, try to harvest something more and make it at least a minimum of that's of your re-tears. Now we move to the third part of the ACL reconstruction. Now there are several techniques defined, sir. Ishwar sir, could you elaborate on the femoral tunnel techniques? How do you point it out, and how do you talk about it for our younger colleagues, sir?
Well, the current trend is to do a anatomic ACL reconstruction. That means that your footprint in the femoral as well as the tibial site should be where the original ACL would stand. Previously, there was this technique of transtibial where you make a tibial tunnel and make your femoral tunnel through the tibia.
So what are your specific jigs for femoral tunnel, sir? Do you use any jigs, or what are the specific methods to make a femoral tunnel?
There are people, like you can do a freehand technique, and then there is this offset jig you can use. And then there are people who use all those measuring tapes, try to identify the point where you want to make a femoral tunnel, exactly measuring what you call that, measuring things. Other techniques like the use of the grids and identifying the point from your with the use of CMs. I think these are not that practical things, using the CM or using the Bernard and Gertel grid lines. The most practical I use is the offset or the femoral offset jig, which should be behind the lateral femoral condyle, from your anterior-medial portal. You have to have an accessory anterior-medial portal when you do a anatomic ACL reconstruction through the accessory anterior-medial portal.
Sir, I would want to ask you another question regarding the same thing, sir. So what's your posterior margin of the femoral tunnel, a minimum which you would require in order to make it? And if you are using an offset jig, what's the diameter difference you would use for what variations in your graft, sir? Could you elaborate on that?
The usual distance you should be aware of, that should be in front of your posterior condyle, should be around 2 to 3 millimeter, So when you use a offset jig, which is usually 6 millimeter, you have a distance of something like 4, the radius is something like 4. If you have a 8 millimeter size graft, the half of the diameter of the graft is 4 millimeters. So when you put a 6 millimeter offset jig behind the lateral femoral condyle, you have a distance of something like 2 millimeters. So that amount of a wall of.
So you maintain a difference of two between the graft size and that. 2
to 3 millimeter of distance from the posterior wall. So if you go further than that.
So sir, I'll give you a theoretical example. If your graft diameter is 8 mm, what's the femoral offset jig you would want to use?
6 millimeters. So 6 millimeter, you see, when you use.
So it gives you 2 spares, right, sir?
The half of the radius of your 8 millimeter graft is 4.
Yes, sir, please, sir.
4 millimeter. Okay, you understand the radius of the 8 millimeter is 4 millimeter behind your point where you put the breath pin. So if you have an offset which is 6 millimeter, where the pin is coming to the center of the pin, you have a distance of 6 millimeter behind the pin. So half radius carries half of the graft, which is 4
Okay.
millimeter goes up to the 4 millimeter margin, and you still have 2 millimeter behind that. That is the safest margin, I would say. Safest wall of bone you should have.
Sir. Silas, sir. Okay, sir. Fair enough, sir. So we have to have a difference of 2 between the graft diameter and your femoral offset jig. Silas, sir, your technique, is it femoral offset jig, or you do a free hand or a clock face or the radiologic?
I do.
So what's your preference?
I do freehand. I think it's important, first of all, to expose that area, to clean up the area properly, to know your anterior posterior margins, and to also feel the intercondylar ridge with, I usually try and feel it with a hook and know where the ridge is going. So I use the anterior medial port with the scope, and from the accessory I put in the bead pin. Sometimes if it I would use an awl to make a opening a small dent first, and use that.
Okay, so how do you locate your point in freehand technique, sir? What's the ideal placement of your?
It's a little bit of eyeballing, but
how do you locate it?
Different discussions.
Is it a clock face?
No, I normally try and see, you look at the anterior articular surface and the posterior margin, and you have a 50% point, and then you go, your bead pin needs to be slightly behind that point, behind the midpoint and below the intercondylar ridge. So because you're, you don't get a bifurcate ridge every time. So you want to get that. So it is a little bit of eyeballing. So that's how I just do it.
Okay, sir. So you stay around what position you're on the clock when you're doing an eyeballing? So is it 10 o'clock, 11 o'clock, or 9 o'clock? What's your preference when you're drilling it?
Well, I'm looking from the anterior medial port. So when you're looking from the anterior lateral, you're looking at which clock it is, isn't it?
Yeah.
So I've got my the lens through the anterior medial and the bead pin to the accessory anterior medial, and you're looking directly in. So well, it comes out around, say, 10 o'clock position, around approximately around that area. But when you look from the anterior medial port, you can see the face of the medial surface of the lateral femoral condyle, and you can feel your point. You feel it with the awl, and you make your dent in that area. So the basic thing is to be below the intercondylar ridge and just be beyond. It's a little bit of eyeballing, but it's beyond the 50% mark. So if you have your bead pin there, as you dilate it, you will actually get in. You leave that bit of 2 millimeter, 3 millimeter at the back. So usually that's how it'll go.
Okay. Fair enough, sir. Sir, Amit sir, can you tell us your experience, if you have any, with using a radiography intraop to locate your femoral tunnel, sir? And what are your preferences, sir? It's an offset jig or eyeballing, or it is a radiography, sir?
I practically never use radiograph for placement of the femoral tunnel, though Hurtle grid has been, Hurtle Bernard grid that Ishwar sir was saying is been described.
Exactly.
But I never use that. Earlier I used to use a jig only, but nowadays I combine the eyeballing technique with the jig, the femoral offset jig. If you put only, as Silas was saying, only use the owl, that was when you used to remove all the soft tissue from the femoral condyle. If you remove all the soft tissue from the femoral condyle, you make a hole, and then you can see the hole very clearly, and you can pass with the eyeballing. But nowadays we do not remove all the soft tissue. We do as much as possible remnant preservation on the femoral side as well. So what I do is I use a radio frequency ablator, and then mark the point on the soft tissue, which is going to be my tunnel for the femur. Then once it has been marked, I switch my scope to the anteromedial portal, and from anteromedial portal, then you see the condyle first. So you see condyle, and then since you have marked that place with your radio frequency ablator, you see that your location of that position is correct or not. So once you have confirmed that the location is correct, then I use my jig and use that jig so that I can reach to the same marking area. So it will make sure that it will provide certain leverage to a very long bead pin, which is very long. And when you pass a 1.8 millimeter bead pin, it will wobble. There is a chance of wobbling, bending. So it will prevent that, and then also it will make sure that the amount of the bone bridge that is required posteriorly is maintained. So it's
and
a
what is
combination
the
of eyeballing and the jig.
I would like to ask one more question to you, sir. So what's the minimum degree of flexion you prefer, sir? You require for a femoral tunnel, just for the younger colleagues who are willing to start arthroscopy, sir. When you're drilling, what is the minimum?
So to explain that, if you do a transportal technique, which is an anatomical technique, minimum knee flexion that is required is 110 degree. That is why in some cases of very obese patient in which the knee flexion beyond 90 degrees is not possible is a relative contraindication. But there is another device for that. If you use a flexible reamer and the flexible bead pin, in that case there is no need to bend it to 110 degree. You can very well do it in 90 degree. So for normal non-flexible reaming, it has to be at least 110, and if it is possible, probably 120 degree of knee flexion is required. Is that answers, Nagmani? Does that answer your question?
Yes, sir. Yes, sir. Yes, sir. Fair enough, sir. That's what I wanted to emphasize, sir. And so let's move forward. What do you think, sir? Arjun, sir, the tunnel placement, sir. We talk about a tunnel. What are your comments on this, sir? You can see the X-ray. Are these tunnels anatomical according to you, or what would you do the same?
Non-anatomical. Non-anatomical.
So what
these are two vertical.
Okay, sir. So basically, tunnel placement is wrong in both of it, right, sir? And if you have
and the superficial on the tibial side.
Okay, sir. Fair enough, sir. So I wanted to ask, sir, how often do we advise radiographs for these cases after post-op? I mean, this is a post-operative radiograph of the patient. So how often do you advise a post-operative radiograph for a patient who has ACL reconstruction, sir?
In every patient.
Every patient, sir. Fair enough, sir. We'll come to that later on. And so I'd like to bring into notice some of this. See, the most important link in the ACL reconstruction is the femoral tunnel placement and the tibial tunnel placement. So there are various papers which talk about it. And one of them, as you can see, it says that operating surgeons are more likely to judge their tunnels favorably than the observers. So it has to also be individualized. And the surgeon who is used to whatever it is, provided it hits 70% of the femoral footprint. If you look at it, independent surgeon reviewers appear to be more critical than results of 3D CT imaging measures. So if you use intra-op or post-op just to check your femoral tunnel placement, it doesn't affect your outcome. It's more of an intra-op reading which helps you in determining whether your tunnel placement is right or not. And when you look at it, surgeons do not agree on the ideal placement for a single bundle ACL tunnel. So exactly to the point, you cannot say whether it's a 10 o'clock or it's 11, or whether you go more horizontal or more vertical. So that's the difference based on this paper. The techniques has already been described by all our panelists. There are various methods like clock face method. Then there is a footprint guide, as Yusuf said, measurement guides. And then there are intra-operative computer navigation and fluoroscopy. And when you look at it, technical errors, according to this paper, result in 22 to 88% of the failure of your ACLR. So this is one of the most critical steps for ACL reconstruction. And if you don't know how to place a tunnel, first see the seniors doing it and then move towards your own practice rather than just hitting and trying it. And it is the most common surgical error thought to be responsible for increased graft stress and eventual failure. The ideal locations, you can see it through these papers. I won't be discussing it, and it has been already been discussed in the first slide by the first speaker and the second speaker. The other also talks about it. The femoral tunnel depth demonstrated the largest range of differences between the surgeons. So tibial tunnel placement, invariably, most of the senior experienced surgeons tend to agree on almost around 90%. And they fall within the optimum area. It's your femoral tunnel where the problem arises. And that's where, because the surgeons, even the senior surgeons, do not agree on the exact method of where to place it. So it has to be individualized, and you have to rotate in order to know that where is the fair tunnel placement for femoral. To take it, your choices of fixation, sir, fixation devices. What are your choices, sir, when you're doing a single bundle ACL reconstruction, Arjun, sir?
Femoral inner button and tibial interference screw, plus minus post.
Plus minus post. That's for your hamstring graft, right, sir? In your BPTV? In your BPTV, both sides interference screw, right, sir?
Yeah.
I would like to ask Silas, sir. Silas, sir, what are your preferences? Endo button and interference, or you?
Just the same, exactly the same as.
So you agree to the tibial fixation post also, right, sir?
Yeah, I normally do for PTB screws up and down, and in hamstrings endo button screw.
Okay. And regarding the post, sir, do you advise putting a post or plus minus? When do you?
In every case, it's only if I have lost a bit of confidence.
Okay. So what do you mean by the loss of confidence, sir?
Agwani, I'll interfere here. I would like to ask Dr. Arjun and Silas that there was a question here in the chat box, like if you're using an interference screw in the BPTV graft, where should you place the interference screw? Because there seems to be some questions from the younger guys here.
It's important to see that you're not posterior, because you'll cause a blowout of that. So you need to be anterior superior to the.
And in the tibia?
On the tibia, you shouldn't be anterior to the graft. You should be posterior.
Okay, thank you. That's cleared
up. Amit, sir, I would like to bring you on, sir, and your preferences, sir, and what are your indications of putting a post in order to secure it, sir? Have you done it, the post securing later on after fixation, or you don't do it usually?
Yeah, we have done it in a couple of cases, but very rarely. And that is usually because I agree with Arjun, sir, the tibial fixation is the weak link of ACL reconstruction. So if I find when I pass my screw, I usually use a double size. And then very important for a beginner, when you drill your bone, when you drill the tibia, make your tunnel, have a feel of the strength of the bone. So if your bone is very, very strong, especially in acute tears, when there is acute tear, in that case, the bone is very, very strong, and probably I, in 99% of the cases, put a 2 size bigger screw, and I feel that good squeaking sound that is coming out when I pass my screw. So only in those cases when squeaking sound is not there, that means there is osteoporosity. Sometimes when there is a bone contusion, bone edema, this squeaking sound may not appear. In that case, I usually supplement with the post.
Fixation post. Fair enough, sir.
Yes.
But
Nagmani, I see a lot of questions coming on where to put the screw and all. It is very important. Let me also elaborate. The position of the screw will differ in case of BPTB and in case of the hamstring graft, soft tissue graft. You understand that if the bone plug of a BPTB has a cortical part and the cancellous part. So have to make sure that the cancellous part is away from the center. So cancellous part towards the wall of the tunnel. And the bone has to go into the cortical part rather than the cancellous part. That is the most important. As far as the location of concern, then there is an important point what you are going to reconstruct. If you are going to reconstruct a posterolateral bundle, so replicate the posterolateral bundle, In the femoral side, you put anteriorly so that it goes posterior-inferiorly, which is the attachment side for the posterolateral bundle. In the tibia, you put it anteriorly because you are pushing the graft into the posterior side again to replicate the posterior bundle. That is the whole principle. Again, same applies to the soft tissue graft as far as the placement of the screw is concerned. But one very important step of BPTB graft is that you have to see where is your cancellous portion of the bone plug so that it goes into the wall. So you do not put your cortex into the cancellous bone. The cancellous bone has to be in contact with the cancellous so that there is a good union take place.
Okay, sir. So for you, sir, your hamstring would be suspensory above and aperture below, and for your BPTB both aperture, right, sir?
I absolutely agree with.
And you don't find any differences
what
between
Arjun
that, right? Okay, sir. Thank you, sir. So we'll move ahead.
Yes. Nagmani, one thing that is Ishwar's Arjun sir was also pointing out about the if you put a screw in femoral tunnel, it makes your graft flat. Yes, I agree with that, but we have to understand that the graft heals at the aperture, not inside the tunnel. That is a very, very important. So whenever you put a interference screw, try to give a structure, a flat structure, it has to be in the aperture. So if there is an interference in the aperture, the healing is really poor. So that is why it has both advantage and disadvantage. So it has to be taken with a pinch of salt and then decided from patient to patient.
Okay, sir. Fair enough, sir. So as you can see, there is no significant difference in knee AP stability or other outcomes if you, with regards to the choice of your method of fixation, and improved overall stability your graft ruptures using suspensory fixation has been. So how does your graft choice, everybody said, their fixation varies according to it, and suspensory both aperture for your bone patellar tendon and for your hamstring suspensory above and the aperture fixation below. Very good from 2018, and it's from a registry of 38,666 patients. And the most common fixation methods were endo-button in them also, and rigid fix in 31% in the femur, and interference screw 48% below. And rigid fix and transfix were used. What they interpreted was the choice of graft did influence the chances of revision after primary ACLR, especially with the choice of graft, that was hamstrings. In bone patellar tendon, it was not of importance, but when you are dealing with hamstring tendon autograft, the combinations do matter. And there is another registry from Norwegian knee ligament registry. And if you look at this table is actually very interesting. If you look at it, out of patellar tendon, you just find number of revisions is 24. But when you come down to endo button and biosure or interference screw, it comes down to 49, and then endo button RCI screw. And in biobable interference screw below, it does have higher chances of revision surgeries. And that's what has been said, especially in your first post-operative year, sir. So, and they advise us to find a better combination. And if you look at it, the transfix to rate of that in their paper, number of patients from yearly cohort being revised after 2 years could potentially be decreased from 116 patients if only hamstrings with the combination of endo button and biosure, that is a bioabsorbable, were used to 32 patients. That is an immense amount of revisions, decreasing if you're using a transfix and a metallic interference screw below. And performing all primary ACLRs with PT would decrease the number of patients being revised only to 15. So that immense number of 116, if you use patellar tendon, and the fixation, your number of revisions would come down to 15. And that's one area I think we should all explore on. And that's what they said. And FC has a significant effect on the patient's risk of revision, especially your graft. Sure, sir. Your preference, sir, a bioabsorbable or a metallic, sir? Because I see almost all our senior surgeons being very inclined towards the bioabsorbable, sir. And why metallic, sir?
Yes. Hello.
Issue, sir?
Yes.
Yeah. Your choices, sir.
Yeah, I usually use a bioabsorbable screw. Very rarely do I use a metallic screw. With the use of bioabsorbable screw, you know, like if you need to do a revision surgery, it is better. And all the metallic screws, metallic interference screw we get here is not the one that is not cutting, you know, all those Indian mates are cutting and it will damage your graft. You know, I'm afraid of using a metallic screw.
Arjun sir, your take on this, sir. Metallic or bioabsorbable? Since you've been fixing your patellar tendons, do you use bioabsorbable or metallic?
These days, Nagbari, I am giving option to the patient also, because what incident I have happened to me is like there is one patient, a sports person, he was fixed with a metallic titanium screw. Then it was being seen in X-ray also. Every time he does X-ray with the pain for other regions, and he removed that screw in Qatar when he had been there for that, assuming that it was the culprit for its pain and so. And so, even literature said this metallic screw is stronger than the this bioabsorbable screw. We are more inclined toward the bioabsorbable screw because of various reasons.
What are your various reasons, sir? Various reasons, because like, those reasons can be elaborate, and it's especially
and the patient wants any implant inside the body that is not visible, that doesn't need to be removed.
Okay, fair enough, sir. Have you had any incidences where you had to remove a bioabsorbable screw, sir, after years, or any complications you have known? None,
no,
sir.
I didn't.
So it's just with the metallic, right, sir? Silas, sir, you take on this. Your is bioabsorbable too?
Yeah, I use bioabsorbable. They say it is absorbed, but I've had it 2 years down the line, it was below the skin. Had to be moved. Yeah, so
okay.
There's always
that's basically on your tibial side, right, sir? Tibial side.
Yeah, the patient, it was like a fistula, and that thing came out. He was all right, but so it can even patient came back 2 years later. So, but I am a bit confused myself at this moment, because the people are gradually going away from bioabsorbable screw too. At present, I'm still using the metal one. I have a bit of a fright for it, because a lot of the screw, it's quite sharp, I find, and whether that's going to destroy the graft, especially the hamstring. When I was my training days, we used to use what we used to do is the hamstring we used to divide into four. We had four parts of it. So in the center, we used to put bioabsorbable sleeve. So and the screw used to go into the sleeve. So that was what previously I had seen. But here in Nepal, we don't get the sleeve system, which that actually protects the fibers of the hamstring to be eaten up. But well, we haven't had problems here. I'd still stick to bioabsorbable for safety reasons.
Fair enough, sir. Fair enough. Okay, sir. So that's your bioabsorbable screw. So when you look at it, like sir said, there is no difference between this was one of the systematic reviews from 2016, which said that there is a very low quality evidence regarding whether to say which one is preferable and which one is not. And this was something which came out in 2016, and people started thinking that, okay, metallic versus bioabsorbable, the debate is done. And since there is no there is only low quality evidence, and there is no increased chances of failures according to them. But when you look at two things, this was another systematic review and meta-analysis which came up. And what it says is that whereas the clinical and functional outcomes are similar in both metallic, that is MIS, and bioabsorbable, prolonged knee fusion, femoral tunnel widening, and screw breakage are more common with BIS. And so future cost effectiveness analysis has to be done, because as we all know, bioabsorbable are more costlier than your metallic interference screw, and yet it is being preferred despite these adverse effects which are being evaluated nowadays. So that's one of the studies. Yes, sir. Arjun, yes, sir, Amit, sir.
Nagmani, let me bring to your, a discussion that probably the metal screw and the biodegradable, come to the biodegradable screw, it is phasing out at this moment. Unfortunately, we have to use biodegradable screw because this is one of the screw which is available at the cheapest cost. But if you go to worldwide, many people are using either biocomposite or the PEEK screw.
Yes, sir.
So these biocomposite and the PEEK screw, they have all the advantages of the bio screw and doesn't have disadvantages of the metallic screw. So probably at this moment, discussing bio screw as a gold standard is not right. This is not a gold standard at this moment. Talking about metallic screw is also not right, because metallic is not gold standard for the soft tissue fixation. Whereas for the BPTB fixation, metallic still holds a very valuable opinion and a very good fixation with the metallic screw. So probably those patients who can afford going to a PEEK and the biocomposite, which is a Milagro screw, as our Silas was saying, which has a Milagro 2, which has a seat and it is a biocomposite screw, probably those kind of things, but they are almost double the cost of the biodegradable screw. That is the only reason, but in affordable patient, probably biocomposite and the PEEK screw is the choice of interference.
Okay. Sir, let me complete this and then I'll come back to Amit, sir, once again. So, Amit, sir, this is one of the cases we saw, if you remember, sir. How often do you see this picture, sir, when you're using a bioabsorber? And
very often, because these are memorized a lot. But if I have to talk about how many cases of these, the cyst formation with the biodegradable screw, I have record of about 10 to 12 cases. One interesting case. This is a case who came after 4 years of surgery.
Yeah, this was where the whole screw came out, right, sir?
Yes, absolutely.
Yeah.
And
look at this, sir. The whole screw comes out, and that's how it is. So Silas sir had similar kind of experience when you were talking about one where there was a fistula, right, sir?
Yes.
Okay. Rajiv sir, have you seen some of these kind of pictures, sir, in your practice?
These screw, I have had one patient from Nepalganj. She presented, I think maybe about 9-10 months later with discharge, and everything was fine. ACL was solid. She went back to doing normal activities. Then she started having swelling over the tibial side, and treated her with admission, antibiotics, and finally removed the screw. She got better. And this thing on metal screws, one small addition on the metal screws. The metal screws we were using when we started off, right? Initially, when the implants were very bad, when I don't know whether the bioscrew had just come in, I think at that time. And when we were doing these hamstrings, for the bone patellar tendon bone, they were okay. But for the hamstrings, they were so scary, because when you put those screws there, the graft gets completely lacerated. So I think that's when we stopped and never went back to metallic screws after that. I've always been with this.
So this is one of the conditions our younger colleagues should know about. Basically, when you see this is not an infection. And when you look at it, bioabsorbable screws, whatever composition it is, can result in a symptomatic intraosseous tibial tunnel cyst after ACL reconstruction. And when you look at this series of 53 patients, when they saw, you look at it, 20.8% had persistent pain in the cystic area despite removal of the screw. And when you look at it, 17%, 22 out of 53 patients had the screw, which was half absorbed, and majority of it was fragmented, which leads to the foreign body reaction, which causes this cyst formation. So that's what they say, complete absorption of. Yes, sir. Can I finish the literature review, sir, and then you can add it, sir? I'll finish it this. And then there is, like Amit sir said, he saw a case after 4 years when he found this kind. And then there is a case which has been reported even after 10 years because of lack of absorption of fixation. So when we say it's a bioabsorbable, that's a myth, I guess, because people say bioabsorbable and most of your patients are like, when is it going to get dissolved? You cannot say that it goes away in 6 months or 1 year, because it doesn't. It gets fragmented, and there are reports where they say it stays in your body until 10 years. And not only that, is the etiology of cyst formation after absorbable interference screw related to a foreign body reaction? And that is exactly the cause, according to this paper. And when they say no cyst had an infectious etiology, meaning all biochemical parameters were normal, no systemic symptoms, nothing. And in all cases, the screw was substantially decomposed and grafts were well incorporated. So the chances of instability was lesser. And when you remove all these things, you find that there is, it doesn't recur. So basically, bioabsorbable PLA interference screw, I think the use should be cautious, especially keeping in mind that so many claims and reports are coming with the specification of pretibial cyst formations. And these are all recent papers. So the natural history, as you can see, there was no evidence that it gets absorbed in majority even after 4 years of your implantation. So technically, it's just the name which we say that it is bioabsorbable. In fact, it is a non-absorbable screw in most of the cases. So the debate is done, and you should think about it. Metallic screw and, like Amit sir said, biocomposite are the in thing now, and we should bring it out. This question, like Arjun sir said, he gets X-rays in almost all the cases. Rajiv sir, Sailas sir, Amit sir, and Iswa sir, all of you, how many of you get the X-rays, sir, and what are your reasons? Is it necessary or not? Like, I know Arjun sir's opinion. Rajiv sir, do you get an X-ray?
Yes, I get an X-ray.
Invariably, right?
Yeah, invariably I get an X-ray because I want to assess my graft placement. Because definitely it is of use to the patient also, medical legally. Second of all, I need to assess whether my graft placement has been proper. So there is a way, I'm sure you're aware of it. You take a true lateral view and how you assess the graft placement on the X-ray, right? 84%, 43%. Yeah, so that's the technique that we use.
Okay. Sailas sir, you also get an X-ray, right?
Yes, I get an X-ray, and I think medical legally also, I think it's important. It'll,
Fair. In spite of literature saying that you don't need to do it, but yes, you consider it as a medical legal thing, right, sir?
Yeah,
Iswar sir.
One is also to look at your tunnel and your medical legal issue. I think that's
okay. Fair enough, sir. Iswar sir and Amit sir, since you both practice together, what are your practices, sir?
Yeah, we get an X-ray, you know. We do get an X-ray, and that is to assess your
immediate, right, sir? Amit sir, your practice, sir?
See, Nagmani, I definitely take an X-ray, but not immediately next post-op day, probably in 2 weeks' time, in 3 weeks' time, when the patient is comfortable to move his leg, you know. And if you go back to my colleagues who do immediate next day X-ray, I request them to go back to their next day X-ray and see how many of these X-ray had true lateral view.
APN.
Most of it, yes.
And
AP
what are the reasons for getting it, sir?
No, I don't get it immediately. I do it after 3 weeks because of the obvious reason that even if my tunnel placement is wrong, suppose, which doesn't happen, but theoretically, if my tunnel position is wrong, what I'm going to do next day? Most of the time, I'm not going to do next. So probably if your intra-op everything goes well, everything as per you planned, then probably I'll not do X-ray immediately next day. I understand for the medical legal purpose, for the planning of, and then rehab also, the tunnel positioning important, but I'll do it after 3 weeks. I'll not do on the same day. Yes.
I agree with Amit. I don't do it immediately post. It's when you take the whole bandage off and the patient is comfortable before, that's when you get it done, because you can't get a proper lateral immediately. It's the patient, you can't position the patient.
Absolutely. And then to inform my colleagues, I have a very simple data collection out of 140 patients of ACL reconstruction. This was not long back in Army Hospital. 40 patient of ACL reconstruction. The lateral view was not correct in 95% of the cases. And then AP view was not correct in 60% of the cases. It came in internal rotation, you know, or sometime more on the external rotation. When there is a pain, patient tends to go into the external rotation. The leg tends to go into the external rotation and the patient is not able to maintain in that position. That was the reason. I agree X-ray is required, but I do not do it immediately after some time. Yes, something happened. Something has happened to Nagmani, I think. He's offline.
Nagmani?
It disappeared.
Yeah, might have electricity, internet, whatsoever.
He's gone, I think.
For a break.
Yeah, probably it's a pretty long one.
Break time.
It's 6:40, I think.
It's already 6:40.
So my question is to Arjun sir and Rajiv.
Yeah.
How many times you have revised your surgery after looking at the X-ray on first day?
Not
Okay, I'll tell you
so
something
far.
of it. Let's okay. Can I answer that?
Yeah,
Okay.
of course. Good.
So Amit, the thing is, I need to assess. Like I'm an orthopedic surgeon, right? So when I do a surgery, I definitely need to assess where my implant is. Okay. Now your talk about getting that internal rotation, I am able to get it, Amit. Okay, but your resident has to be reliable, or your fellow has to be reliable. He has to make sure that he does it with both the condyles overlapping, and he takes that shot. It is not very difficult. With modern X-rays, you can turn the tube, like your C-arm. Okay, but we have studies going on to assess on the radiograph the quality of fixation. So to complete those studies also, you need to get an X-ray. And yeah, you can get the X-ray done after 2 weeks, no problem. But it's easier because see, we are a multi-specialty hospital. So after every routine surgery, the patient with an implant, the patient goes in for surgery. So as a matter of protocol, we go in and get the X-ray done. It is definitely difficult to overlap those two condyles, right? But it can be done. And I don't think it should be such an issue. I don't have any problem with people getting it 2 weeks back, but it's not such an issue.
Okay, sir, sorry, my internet connection was unstable. So I'll move ahead with the literature review regarding this.
You needed a break.
No, I didn't, sir. Still
it's going to be 7
back.
o'clock. It's going to be 7.
Yeah, just a couple of slides, sir. So when you look at it, there are studies, and this came around in 2015 initially. Post-operative radiographs after ACL reconstructions are not cost effective. So when we are talking about medical legal cases, first of all, let's forget about it because it's not going to happen. There are multiple papers which we can quote as a reference to say it's not going to. You will not be sued in the court of law, and if you get sued, you can actually counter-sue them to get the money. So when they saw and they got 54.4% of the patients, they found out that no radiograph showed a complication if it was done by an experienced surgeon, that they changed their post-operative care. Like Amit sir said, immediately getting it, he's not going to change that. Even I think Rajiv sir doesn't change it, even if he finds certain minor faults. If I'm correct me if I'm wrong.
I have something to say to that, Nagbani. You want to finish, then I'll say something.
Yeah, I'll finish it, sir. And regarding the cost, no matter what we say, even in developed countries, per patient, the charge increases to around $42.62, sir. Even in Nepal, though the price might be less, but when you're submitting a patient for radiographs, you are not getting to find anything, sir. And it should not be considered. That's what they said. It should not be considered as a routine practice and are recommended only when your symptoms post-operatively suggest a mechanical complication or in cases of unforeseen post-operative trauma, when you're suspecting that. The other paper, I'll add on to it, and this was more recent one, and when it says this also evaluated, and they said that it is questionable because it doesn't yield a clinically meaningful result out of it. Rather than just seeing tunnel position, but you're not going to significantly change your post-operative management as they have recommended. And they say that these results suggest that routine radiographs after uncomplicated ACL reconstruction means unnecessary, although larger multiple center studies are needed. So Yes, sir.
Yeah.
Rajiv, sir, what
So
you wanted to add, and then we'll proceed, sir.
Yeah. What I wanted to add is, okay.
So medical legal thing is out, right, sir? Rajiv, sir, you agree to it that it's out.
Okay. Just let me place my point. Okay. The thing is, see, basically, we as expert surgeons done many ACLs. You might not want to assess. You're confident about everything. But remember, this is a basic knee webinar. So if you're going to tell your basic ACL surgeons don't do an X-ray, there's going to be a mess up. Do you remember X-rays that was shared with the endo button in the condyle?
Yes, sir.
Do you remember
but
that?
I think that can be seen intraoperatively, right, sir?
Yeah, exactly. No, that cannot be seen. If it's inside the condyle, may not be seen by a young surgeon. So I think, see, after every implant removal in my hospital, we get a C-arm shot on the table.
Okay.
Okay, is that necessary? No, may not be after a resident does it. Because see, if that is not taken and it is left inside, I can tell you what will happen after that.
Fair enough, sir.
So I think our practice, according to you, shown a lot of beautiful literature. I agree with you 100%. Okay, 100% I agree with you, right? And a lot of stuff, literature from all these countries in America, right? But remember that when you do practice here, I think it's important to take a post-op X-ray. Okay, as a matter of routine for a basic webinar. If you're talking about on the expert level, definitely, okay, you can ignore the X-ray. Okay, but my message to junior surgeons would be that take an X-ray. Okay, at least for your first 100 cases, take an X-ray. After that, okay, you become an expert, go ahead.
Fair enough, sir. Fair enough. So we have reached a compromise, right, sir? 100 cases and then we can change.
Maybe
that's the beautiful compromise. Yes, sir, Silas.
Yeah, I'll tell you, we're talking about X-rays, yeah? When we went to Japan to see, they do intraoperative CT after AC. Okay. Every patient with an ACL, they do double bundle. They were doing an intra before the patient, the surgeon finishes writing his notes. The intraoperative CT scan is done, and the tunnels are looked at. At the level of, it's also trying to improve yourself with every move over period of time. We are all learning. Yeah, no matter how experienced.
Fair enough, sir.
So, and
it's very important. I feel no matter what literature says, there are three types of lies in this world: lies, damn lies, and statistics. Yeah, Mark Twain said that.
See, the thing is basically
the best lie.
One minute.
So don't look at it. Be careful about literature.
All are agreeing on nobody.
Amit sir, you can chip in when you want, sir.
Yeah, one second.
Among the panelists.
I'm talking in favor of what he's saying only. Amit is not saying that he won't do X-ray. He's saying he'll do it later.
Okay.
So that is okay. Justified. Okay, and Amit is a very good surgeon, man. You can't say that. You can't start a beginner with him. Okay, I mean, come on.
The other thing, you know what? The other thing is, like we are in the habit of doing X-ray. You fix a fracture, you go to the round, you look for X-rays.
Absolutely.
No, even for the patient satisfaction also.
Let us come to a different compromise than what Rajiv wanted to.
Okay.
So if you are surgery, listen.
We agree with the literature. We agree with the literature. You have to be practical, man.
We agree.
So what's our compromise, sir? Compromise.
See,
what's our compromise, sir?
Listen, no, first. If the surgery goes well, everything is perfect. You do X-ray after 2 weeks. It's easy for you. Not everybody will have a resident like Rajiv.
Absolutely.
If your surgery, you find certain thing fishy in surgery, something went wrong, something was not right. You have made a tunnel little anterior, or your, something is wrong, then probably it's worth, rather than sending your resident, go yourself and do an X-ray.
Amit, let me comment.
Wait. Final thing. If something is wrong in your operation, rather than waiting for next day, get your C-arm right there. Look at your button, look at your screw, look at your position. So 3 consensus. If it is horribly wrong, get it done intraoperatively. If there is something, you see that after reconstruction, there may be something that could have been changed, do it next day. If everything is okay, then probably you wait for 2 to 3 weeks and get it done.
I think you know that
Let us not
X-ray
like be Oli
yeah.
and this thing. Let's
Yeah,
be like
wait 1
friends and
second.
come to
Hey,
consensus.
let's leave our politicians out of the way, man. Politicians are not supposed to be talked about. Listen, 1 sec. What I'm trying to say is that X-ray that we showed with those screws, right, which was vertical, and the screw which was anterior. If that X-ray had been done on day one, maybe we could have done something to help the patient, right? Now, after 2 weeks, you tell the patient, oh, I did the X-ray after 2 weeks and it's a mess. But on the first day, there's a lot of things that you can correct. For the beginners, for expert surgeons, yeah, I agree. Definitely, you'll be able to assess, and you do your X-rays after 2-3 weeks.
I think, Rajiv, even that X-ray that procedure was done about 10-20 years back. You know, at that time it was okay. You know, transtibial. That is the.
No, I'm
best
talking
thing,
about now, right?
Yeah,
Things
right
which were
now.
okay previously are not okay now. Not okay now. Patients are demanding. They know exactly what they get from your X-ray, right? Patients are very well informed now. So it's to save yourself from the hotspot. I think an X-ray, big deal, not a CT scan.
Sir, let's move on, sir. My internet is pretty unstable, sir, and it can go anytime. So we'll finish the last part of this, and then we move on.
Well, now he is gone.
No, sir, I'm there.
Okay, finish it
up.
So
rehabilitation protocols, right, sir? Rehabilitation protocols. So the basic aggressive rehabilitation protocol, we all agree to it, sir. The most confusing part about a rehabilitation protocol is return to sports, right, sir? For all of us, it's return to sports, which is the most confusing part. Now, I would like to ask Arjun, sir, what's your criteria of letting a patient know that they can go and play actively to the basic level which he dares to participate in? And what are your criteria? What do you see for in a patient before you say that you're fit?
Yeah, that also depends upon the type of activity patient is going to do after surgery.
Exactly, sir. I am a sportsman. The first case, the index case which we use, national volleyball player. What would you do?
Okay, the knee should be silent. There should be full range of movement. The strength of the quadriceps and hamstring should be around more than 85%, they say, but around 90% and so. And in different proprioception examination, the patient should fall within the normal range.
So what do you mean by proprioception examination, sir, for the younger colleagues? How do you,
there are basically, I do ask to perform some hoop test, okay, and then cross leg, opposite, like back
and then plyometrics and all, right, sir? The lady jumping here. Your indication, sir, Rajiv, sir, when do you say that the patient can go back to the sports?
I think there's a series of tests that the physiotherapists perform, right? They see a sports physio, and
so basically you see at sports specific drills according to physiotherapy, sir. But as a surgeon's perspective, because
as a surgeon's perspective, as a surgeon's perspective, I see whether the knee is stable or not, right? After after the patient assesses, basically. The time is also very important. So I wait. So at least I wait for 6 to 9 months, right? And it depends on the type of graft that I've used also. So if I've used a bone patellar tendon bone, probably the patient can go back earlier if the patient has achieved bone-to-bone healing. And if it is
minimum time duration, sir, do you set a minimum time duration when the patient asks you?
I think is at least 6 months. At least 6 months. And I take help from the physiotherapist. Yes, Nagman. I take help from my physiotherapist.
Amit, sir, your opinion, sir. Quickly, Amit, sir, your opinion. And
return to sports is not me who decides. It's my physiotherapy actually decides. But
absolutely.
But my share of finding is the quadriceps strength, the size of the quadriceps, the proprioception test, and the plyometrics. So if someone who can do a side-to-side, hop like you are showing, I think its patient is good to go to physiotherapist to decide either he is good to go for sports specific activities. So once the patient starts doing sports specific activities, he himself will say that I'm good to go back to my sports or not, or I'm not having so much of confidence. So based upon that, we'll decide what either the patient.
One more thing,
sir, do they ask you, sir, Amit, sir, do they ask you about the duration? Like when can I go back to the sports? Most of them do ask, right, sir?
Yes. All the patients, they ask when they can go back to their sports. I say that it will not be earlier than 1 year.
Yeah, can I add something? Can I just add one very important point?
Yes, sir, Rajiv, sir, quickly, and then Ishwar, sir, and then we
very quickly. There is one point that I want to highlight. Okay, there's a reason why sports people don't return to sports. RTS, right? It's very high, maybe about Nagmani 20 to 26%. I think.
Yeah, exactly.
Because of psychosocial problems, they have psychological problems. So if some players have come to me who have needed some counseling prior to the OT because of the fear, right? So maybe pre or post op, because your surgery may go perfectly, your physio may go perfectly, but some of them don't return because of that fear. So I think that aspect also has to be looked into. That's all I wanted to say. Sure,
Nagin, I just want to point out here, you concentrated more on the sports person, but when we talk to our younger colleagues, how many of them treat sports person? We should focus more on the normal people, like what are the
so what is your time duration, sir, in those kind of patients also?
I totally agree with what our colleagues said about taking a sports person back to his or her, activity. But usually for a normal person who is not a sports person, who is a simple person, by 2 to 3 months, he should be able to walk and go around. And the other thing is, like, if you if you are treating a sports person, you have to.
Sir, but I would like to ask you, Ishwar sir, our terrain is very difficult terrain, and lots of people come from, and then you need a training. Yes, sir.
Training in the sense that you have to give him or her the time to heal. That is usually 1 to 2 months, but people who are coming from the field, people who come from the mountain, there are patients who come, fly from Jumla, have their surgery here, and then fly back and start going back up and down in the heels. For that you have to protection with braces, and and the other thing is, like, in those places you don't have physiotherapists there. So when we are talking about a sports person, that is a different. But for our general population, for the younger surgeons, who will be treating more of the normal.
So what's your, sir?
So for them, what I say.
So the people who are coming from Jumla, sir, what is your time duration which you tell them that you can go back to climbing downhill and going uphill?
What I have seen them do is usually by 2 to 3 months, when the healing has occurred, the bone, the tendon has kind of healed up, and they are more stable. You assess clinically, swelling is gone, he or she has a stable knee, and then you can, even with protection, I tell them, when you go to a hilly terrain, you should still wear your braces for at least another 3 months. And not only that, it also depends, like Rajiv just pointed out, the mentality of the patient. It's not just the normal people, but also for the sports person. There was one person, I forgot his name. This tall Russian guy, who was being treated by Dr. Freddy Fu. And Dr. Freddy Fu was saying that this guy could go and play his sports within 3 months because he was that person, Ibrahimovic or somebody.
Ibrahimovic, yeah, correct. Ibrahimovic.
The mentality, lot of things counts, the circumstances where the patient is from. And for our younger colleagues, they hardly treat sports person or a sports woman or a sportsman. We should, be more in the safer zone. People usually are coming from the hills, even in the Tarai, like, they have access to transport, they go on walking. So we have to be like 2 to 3 months, very protective, and then, make sure that the strength is back, the girth of the quadriceps is back, you have a stable knee, and the knee is, silent, and then probably then they can take over on that. And I usually tell my patient, from the villages, that they should be wearing braces for, when they climb up and down, go to the dhara to bring the water, go to the, jungle to carry on with the heavy work, should be wearing a brace for maybe a 6-month period, or at least,
But you can get a most important information from the patient themselves. If they're like everything is fine and they are confident, they start asking, when can I go to the pre-injury activities? I'm not saying pre-injury sports activities or pre-injury activities.
Usually 3 to 6 months, I would say.
Yeah.
Okay. I think we are at the end of, where is Nagmani gone?
Again, I will let it.
Already taking a break.
Nagmani is in break.
So, I think we should wrap up, it's nearly
7 o'clock it's already.
Yeah, 3 hours. Okay.
Without Nagmani, I'm going to close this down, but I just want all of you people opinion, like, we should have this interaction in the morning from next time?
Sir, sorry to say, my internet actually keeps on going out right now, sir, because of everything.
Okay, Nagmani, I was taking the opinion that we should have our next time our S1 webinar in the morning on Saturdays, not in the evening. What do you say?
Yeah, yes, sir. Yes, sir. That's the better option. The internet load is lesser, and then these things do not happen.
In the morning, we will be more energized. We will finish in 2 hours so that we have more things to do on the day.
Then you will take more, probably 4 hours, sir. Even now we are passing with less. Is 3 hours.
We'll start at 8:30 and finish by 10:30 at the.
No, 9 o'clock. At least 9 o'clock. At least 9 o'clock.
Saturday, I'm out cycling.
Before or after 9?
That's what.
No, it's not every Saturday. You do your cycling in the Friday evening.
I do every Saturdays. Every day I do cycling. So Saturday I'm out also.
We'll discuss. We'll talk about that.
Okay, sir. I'll stop sharing, sir. That was the last slide, basically. So I'll stop this now. Panel discussion.
Okay. Thank you.
Yeah.
Okay. Thank you, everybody. And I'm sorry that 2 of our eminent speaker ran out on us. I can't thank them. I hope they get the thanking. I hope that they will have a longer, commitment for us from next time. Otherwise, we will not invite them.
Okay.
Anyway, thank you, everybody. And it was a very good, 3 hours we spent together. I hope that we can continue with this. Thank you very much. Okay, I think we can wrap up here. It's long enough.
Okay, thank you, sir.
Okay, okay. Thank you, everybody.
Thank you, sir. Good night, sir.
Bye.
Good night.
Good night.
Good night.
Bye. Good night.
Thanks a lot. Right?
Thank you.
Good night.
Bye. Bye. Good night.